move us on then to our kind of Q&A panel. So Steph, Thea, Alison and Gabby are kind of available now for us to kind of reflect on kind of everything we've heard today and answer some questions that people have about any of the findings, mine included. I will kind of try and manage the chat, but if there's anything for me, I'll obviously answer that as well. But I will kind of stop sharing my screen so you can see everybody. But please do kind of either put a question in the chat if you don't want to come in. Alternatively, please do raise a hand. But I will stop sharing my screen and potentially start, I guess, with a question, well, kind of probably a statement more so around some of the dialogue that's happened around the Community Nursing Safer Staffing tool. And I don't know if anyone wants to come in on their reflections or thoughts. I can see there has been quite a bit of conversation in the chat, or any experiences people have heard of or had.
I'm happy to start, Alison, if you want. And then, oh, sorry, Sally, do you want to come in first?
Let's enable, or just get Sally's enabled. Oh yeah, you should be able to come in now, Sally. You have to take yourself off mute, I think. I think we've enabled your mic, but you'll have to then unmute, I think.
Right, got it.
There we go.
Yeah. Yeah, it was just, I did put a thing in the chat, and I know Alison really doesn't like scheduling tools, but we get more from our scheduling tool than we do from the CNSST. So we get all of our deferred visits, and we get our hours that we need per day, hours that we've got available. Yeah, the CNSST, I don't think it can cope with the complexity of us bundling visits. So we're making every contact count. We've got lots of activities that go into a visit to make sure that we're not task orientated and that we're making sure we've got that holistic assessment, and we're doing all of our we might be going in to do primarily somebody with bilateral wounds, but we're doing all of the bit around that as well, and the prompts are in that scheduling tool, and that is a much longer visit than is allocated in the CNSST. So when we're churning our data into the CNSST, what we're getting out is less than what we've got, and we can't manage with what we've got because we know we've got deferred care every day. So I think it's about the complexity of district nursing and the way that we make every contact count, and it's a task orientated focus.
Thanks, Sally.
I don't really want to be very outspoken though, but yeah, you know, those of you who are on the call that know me know that I'm not short coming forward. It's got a lot of improvements to catch up with the complexity of the care we deliver.
Thanks, Sally. Jill has asked in the chat, which scheduling tool are you using in North Cumbria?
Well, we're using eCommunity. And you know, you can pull your deferred visits off. You can look at whether you've got any harm. And I love Steph's analogy of deferred visits being corridor care in the community. I'm using that every opportunity. And then you can break it down. So you can break it down by your patient. You can break it down by the activity. You can then go back and cross-reference all of those, and it tells you how many times you've deferred the patient, how long you've deferred the patient for, and then you can take a cross-section of those patients, go back into EMIS and see whether they've come to any harm. And what you usually find is they've been seen for other things. It's just that particular visit's been deferred. But yeah, I mean, eCommunity, it's given us so much more. I can have a sensible, articulate conversation about what the value of our district nursing workforce is and what goes into a contact.
Brilliant, thank you. Did anyone else want to come in on the CNSST? Oh, Nicola, we can enable you. I don't know if it's about the CNSST unless you haven't, or you might have another question, but we'll enable you to come in if you'd like to.
Hi, yeah, it's about the CNSST.
Perfect.
Hi, Steve. Because I am a fan of the CNSST, but I think part of that is because maybe in the trust I'm in, we're probably quite behind the times. We don't have scheduling tools. We have virtually no data, and the CNSST has allowed us to get data, to engage the staff, to start thinking about what they're doing every day, to have some sort of validated tool. How good that is or not, but it has given us a baseline, and it's given me a baseline to start thinking about how do I capture unwork done, how do I capture deferred visits, how do I look at harm that I didn't have before, and that's what's been the benefit for me. And in the east of England, I did put it in the chat, we have got a community of practice now where we're starting to develop across the region what are our red flags, what are things that we need to worry about, and that has been really beneficial for me. As a head of nursing in a community and mental health trust with a lot of mental health focus, the CNSST has really given me that tool to present data in a way that the board can understand.
Thanks, Nicola. Steph, do you want to come in next?
Do you want to bring Tracy in first, Rosie?
Yeah,
and I'll come in after everybody's asked questions. That's fine, thanks.
Perfect. Tracy, do you want to come in next then, please?
Hi, everybody. We use a scheduling tool. We also do the CNSST. Our data from both elements is quite significantly different. Also as well, our scheduling tool doesn't really do what we want it to do on the tin. So it's not saving staff necessarily the time. And what it has done is it's stopped a lot of the coming in to have a proper handover scenario, because basically they're allocated the whole day to be out on visits. I've been out this morning, that's why I'm in uniform. I've been out this morning on a back to the floor visit with the bladder and bowel team. They've just gone on to the scheduling tool. Ours is Civica, was Malinco for those of you that have known it in its previous name. Every time we stopped, there was such a waste of time while we waited for them to be able to log in to say they'd arrived, to be able to then go in and do what they needed to do, to then come out and log out. There was just time wasting, and I will be picking that up because our contract with Civica is due for renewal at the end of this financial year. So I may be contacting you, Sally, about eCommunity to find a bit more out and see how well it works. But yeah, there's pros and cons for everything. We've just recently done a CNSST census, and although we have looked into it a bit deeper, and it showed that we needed less DNs than we currently have, we thought that was wrong, because we think our skill mix is pretty much where it should be and in line with what the guidance is. But even so, we knew it was wrong, and it's all about that professional judgment, isn't it, and how you look at it going forward. But we're in the process of actually taking our first paper to board for proper staff establishment review.
Brilliant. Thanks, Tracy. Gabby, did you want to come in next?
Yeah, just on both those points, we've been looking at an e-scheduling tool as well, and had a review of everything out there. There was 3 that were then shortlisted. 1 was clearly no good. The other 2 are the 2 you've mentioned. Promised a lot. When we actually talked to other providers who are using them before we signed anything, found actually it's not quite as it seems, and it doesn't help us manage the deferrals very well. We really wanted to be able to track deferrals and for them to flag when people have been deferred plenty of times and that type of thing, and it just couldn't do that. It's got the potential to, but it hasn't. So we've sort of shelved that for a moment. But in the absence of that, we will, in phase 1 of the CNSST rollout in 2023, and the way we did it, we did find that our gap reflected our deferrals, and it was so helpful. For the first time, we've been escalating the capacity demand gap for over 10 years to commissioners, to the exec board. Before that, it was only when I had the CNSST data that showed a large gap that it spoke the language that people understood, and we could really show how that gives risk. And since then, whilst there is no money, there is at least a recognition. District nursing top of the list on the risk register for the ICB and the trust. And the ICB have started a district nursing review across our ICB because of that sort of escalation we've been doing. So it has helped us. But yes, it's not perfect. There's lots of issues with it, but it was better than what we had before, which was essentially just no useful data at all that anyone would take seriously, and not the right language to be able to, or formality that we could present it with compared to CNSST.
Thank you, Gabby. John, did you want to come in?
Hi everyone. So yeah, we use both a scheduler and we've been doing CNSST as well. Our scheduler is within our EPR, so we use Autoplanner. And what we've definitely found is that within our smaller teams, it does seem to work pretty well. It's within our larger teams where obviously we're deferring lots of activity is where it's really challenging to use it. From a CNSST perspective, I think I'm part of a Southeast network in terms of us rolling out CNSST across the Southeast, and we're all kind of finding the same thing, that it is telling us that we don't need as many staff as what we've actually got, but we know that that's not particularly right. I think one challenge that I have with it is around the multipliers and how are those multipliers worked out for each category of visit. We don't ever seem to be able to get answers from that perspective, because that then comes under the licensing, and so it's like we can't question, well, how did you get to that multiplier for that category of visit? And that's my one challenge I have with CNSST. But I think the advantage is that we definitely need a tool, a national tool, for us to be able to work out what our capacity demand is across our services. And if CNSST is what it is, then that's great, but let's all work together to try and get it right and accurate. I think is what I'd like us to be able to do. And I think the advantages of having both a scheduling tool and using CNSST is that you can benchmark against each other then as well. So you can look at your CNSST data and see how that compares to what your scheduling data is telling you as well. So that's one advantage, I think, of having both. That's just my comments. Thanks.
Thanks, John. Steph, I don't know if you did want to come in now.
Yeah, thanks, Rosie. Really interesting listening to what people are saying. So a few views, some of them a little bit cynical. So CNSST in its original form, I think, was on the right lines. It was clinically led by the clinical reference group that I co-chaired. And I think we were getting it right. I think the problem that we didn't have was that NHSE would not allow us to go and talk to people like Alison, which is very short-sighted in my view, because why would you not speak to an expert? Doesn't make any sense. I think since then it has been taken back in-house to NHS England, and I think they are using this in a way that they want to use it. And not in the way that we wanted to use it. So that's, I probably won't want to say any more on that, but I don't think it's where it needs to be, is what I would end by saying. I think, you know, if it's showing you that you've got too many staff and you need to lose some staff, but yet you're deferring care every day, then quite clearly it's not doing what it's meant to be doing, is it? And at the end of the day, any safe staffing tool is just a marker, isn't it? It's not a, you know, it's not gospel. It's not, it doesn't mean that you have to have that, because things change and stuff changes all the time. On scheduling, I was at a really interesting event yesterday evening, and I will put a link in the chat in a second when I finish speaking. A company called Heim, who have been doing some work with Lewisham and Greenwich Trust down here in London. And it's really quite impressive, the work that's going on. So it is a scheduling type tool, but actually it gives you a real-time data set of what's happening at any moment in time in your caseload, so you can see at a glance how many visits are being deferred right now, how many visits have had to be cancelled today, how many visits you've moved on to another day, how many visits are actually being done, when an urgent call comes in, how you can look at moving things around to get the right person to that patient. It does look really, really impressive. Now, obviously, I'm only talking from what I saw yesterday evening, but it is clinically led. So it is being led by medical and nursing staff who understand this and spent time with community teams to enable them to understand it further. The bit that they haven't yet cracked, which most of these places haven't, is how that then links with the EPR and how you get the two to talk to each other. So there's still some work going on, but I did feel really positive, did that last night. So yeah, hopefully there's other things on the horizon that might help us.
Brilliant. Thanks, Steph. Does anyone else want to come in on any of that? Alison, Thea, or we can move on to a next question if not. Alison?
Yeah, I mean, I think with any of these things, they're always going to be wrong. No model is ever right. Just some things are more useful than others. So it's knowing where the limitations are on them, and that is the key thing. When we see SNCT in hospitals being used, and it's reasonably okay, but we know it underestimates workload, and I'm guessing this will underestimate workload too. But because we know where its weaknesses are, it's easier then to think about its use. And then you've got the behaviour of the people using the tool. So sometimes what we see with the acute version, the hospital version, is, Keith, when he first developed it, really emphasised professional judgment and the being ready for action part. And we see that bit degraded. So it's like, what you want to avoid with any of these tools is treating people like Amazon drivers. So if everything's a task and everything is a timed task, then it's really easy to use these things. But you've heard how complex this work is, and that reduces its predictability in some ways. So as long as you can use the tools but understand their limitations, then it's fine to use them. It's when that doesn't happen that there starts to be problems.
Thanks, Alison. Okay, I will take us on a different tack now and just ask a slightly different question to the speakers. And it kind of builds on something I think Joe put in the chat earlier around the new NHS long-term plan. So given kind of what you've all presented and what you've shown today, from your perspective, or the data that you presented, or the findings you've had from discussion and things like that, what needs to happen to district nursing services to prepare them for the long-term plan, in your opinion? Quite a big question, but might as well ask it whilst we've got you on the call. I don't know who wants to come in first, but Gabby, shall I go to you?
I'm just speaking for my trust now, not the whole of the CNEN. But in my trust, prior to the 10-year plan and coming out, we had a clear vision of where we thought integrated neighbourhood teams should be going, and the leadership of that being really with these core services, and that district nursing potentially has the skills. It's just that they can't use them because they're taskified. But it needs additional resource. It needs some pump priming to allow the change. That seems to be the biggest thing for me. I think it's overstated how much the integration will solve all the issues in primary and community services, and release lots and lots of capacity. For me, that feels overstated. But even if it wasn't, to try to turn things around when people are barely hanging on in every service, to do a big transformation piece of work about how you're going to work, I just don't think it's realistic. And you need some investment to allow people some time to think about it and to work differently and set up new models potentially. It feels like you're set up to fail.
Thanks, Gabby. Steph?
So there needs to be some brave decisions about funding models for me, because that's where fundamentally this has gone wrong, for me anyway. At the moment, the only place that can get more money is a hospital by doing more activity. If we do more activity in the community, we're just expected to suck it up. So the funding models need to change. And I know that is in the 10-year plan, and I know that is being discussed, but that needs to happen quite urgently, I think. I think then the other thing is the thing that I've been saying most of the day, really. We need to understand at a national level how much community corridor care is actually happening. And I would hazard a guess that there is more care not done in community than there are people being cared for on corridors in hospitals. And this is not a competition, because none of that is right. I just want to be really clear. I'm a nurse at the end of the day, and a patient being nursed on a corridor in a hospital is clearly not right. The other question I'd just ask this group of people is, do your boards know what are happening? Does your chief nurse know? And particularly if you're an integrated trust, do your chief nurses know how much care is being deferred every day? Do they know what harms are happening as a result of that? Because I can see some nods, which is great, from Gabby and Tracy and Sally, which is brilliant. But I know that in some integrated trusts, there's never a paper about community nursing that goes to boards. And therefore, how on earth, if your board hasn't got oversight, how can you know what's happening? So those will be my thoughts.
Thank you, Steph. Thea.
Yes, I'm about to paste in a piece of work. And going back to what Gabby said just earlier, there is no evidence internationally that you can create better community services by decommissioning and taking money out of hospitals. Doesn't work. There's no evidence that it works. Sorry about that. But what does work is if you properly invest in your community services, you may well free up capacity in your overburdened hospital to allow your hospital to be a more productive, more efficient, more compassionate and better place. So it isn't that doing this work and ensuring that the work is properly funded and supported in the community does not have a level of significant impact on a hospital, but where most hospitals are working at 95% occupancy, they are not efficient, they are not productive, etc. If you therefore do the work that means that you maybe now have a hospital that's at 85%, what you're not doing is closing wards and bringing a load of money out into the community, but you are making that hospital a better experience for everybody within it and the patients using it. And there is no international example that you can simply shift money. So I keep saying that at a national level. Makes me very popular.
Gabby, did you want to come back in?
Yeah, it was sort of along those lines. I agree with you. We're not going to get the left shift of money. It's got to be new money or a public decision making honesty from central government, which then no party's ever going to do, because it's not a vote winner. And this is why it just rolls on in 5-year cycle. But anyway, let's not get into the political thing too much, because I really could, especially on a Friday afternoon, go down that track. Anyway, what I was going to say was, yes, we are, like many people have said in the chat, escalating. Since we've had CNSST, we've been able to escalate more, have more attention, have more support for our escalations. And as I say, we've triggered this ICB review. But we did something a bit strange, but 4 years ago, we declared we were on Opal 4 in district nursing, which people did not like, but I continue to say we are. But, the whole system has sometimes argued back to us that actually, if you're on Opal 4, and that's been for 3 years, 2 years, 5, now 4 years, and it was before, I just didn't think of calling it Opal 4 before then that really, you're not, because if that happens, literally it's only for a few days or a week and then it has to resolve. So if you are, that's just your new normal. That's what district nursing should be, or is now. So I've completely resisted that. But where we're reporting the amount of deferrals, we're managing them so carefully, if you like, almost so well with our prioritisation framework, that although we are getting a lot more complaints, we are getting some harm, sepsis, death, even admissions to hospitals from people with infected wounds and things like that. There's almost become that sort of escalation fatigue in the system because everyone's hands are tied. There's no money in the system. In fact, we've got to make huge SIPs, even from community services are already in this position. So yeah, it's a difficult one. I continue to escalate and continue to try to find patient stories and things like that that will illustrate that this should not be business as usual and how it could be. But that vision of how it was and could be, a modern version of that, is so far in the distance backwards now that it sounds like pie in the sky to people when you're trying to say, look, if you invested in district nursing, if you invest in district nursing, we could do this in neighbourhood teams, and we could do that, and we could prevent that admission, and we could, you know, coordinate the whole of palliative and end-of-life care. And I know that because I did it. I've lived it, and it works, and we did not have these complaints and things like that. But it just feels so far away that I really do think that everyone in the system at very high senior positions are sort of at a loss about what to do with district nursing, really. And it's so big and so expensive. So anything you do is going to cost a fortune, although it's very cheap at the price. So it's very difficult to turn that oil tanker around, despite escalating harms and things like that. There's just, I mean, our trust has found some money and they've gone overspent because of it. And we've over recruited. I think we're at 130% over recruitment now, and we've still got massive deferrals. I mean, it's over 400 deferrals today, even with an over recruitment and escalations and reviews. So but at least you feel like you are not holding the responsibility for that anymore. And you're managing it well, because actually there's an amazing lack of real harms because we're managing it so well as service, as district nursing always has and always will do, I'm sure.
Thanks, Gabby. Thea, we're very close to the wire, so I do need to hand over to Steph and Laurie. So if you can make it about 10 seconds, please do come in.
Yes, I was going to say we are very close to the wire. I was going we worked out we'd be 347 million nationally to bring district nurses back to where they were in 2009. That's nothing at a national level, but I do appreciate that at a local level it will always be incredibly hard to get money. But it's been sobering and useful to listen. Thank you.
Thank you. So in the interest of time, I will just pop up our final slide. We will pop a survey in the chat, so if you've got any feedback, please do feedback. But I will hand over to Laurie and Steph for just any final comments from either of you. But thank you to everyone for joining us today.
Really interesting session and very well run. Thank you very much. Great to hear that there's such a thirst for good data as well. I won't say any more. I wish you a great weekend. All the best.
Thanks, and I'd just echo that. Thank you, Rosie and team. It's been a brilliant afternoon. Some sobering information, but I think there is some positivity there, and we have to seize on that, and we have to work together. So thank you all. Have a lovely weekend.
Thank you all for joining us. As I say, we will share what we can after the session. Partway through my presentation, I realised my slides weren't quite the most recent ones, so you might see a slightly different version, but they're the same metrics. But yes, we will get that shared afterwards of what we can, and then when those other reports get published, we can share that too. But thank you for joining us. Please find out more about both organisations on the screen and do respond to the survey, and have a nice weekend. Thank you.